Mlango pia usitofunga pia. Basi funga madirisha nasi.
Yesterday. But is it the general manager or manager yoyote? Kwa sababu general manager hayupo hata. Okay. Ready? Sa. 3, 2, 1. Okay. So yesterday we looked at the ABR. Today we'll talk about two topics. So first we'll talk about something that we started talking about yesterday, about the patients with atresia, with conductive hearing losses. We'll talk about the prosthetic management of conductive hearing loss. Of course, we know that there are other management options for conductive hearing loss depending on what they have. So if the patient has otitis media, you can treat them with medication, you can treat them with surgical intervention, grommets, things like this. But we'll talk about how we can use prosthetics to manage conductive hearing loss and mitigate the effect of hearing loss in patients with conductive hearing loss. The rationale for this is that the conductive hearing loss, first of all, has a variety of causes. So it can be, eustachian tube dysfunction or acute otitis media. It can be chronic conductive hearing loss caused by chronic otitis media, glue ear, otosclerosis, ossicular chain discontinuity, tympanic membrane perforations, a variety of causes. And any degree of hearing loss, which is something that we know, can cause adverse effects. So whether you have a mild hearing loss or a profound hearing loss, there are negative effects of having untreated hearing loss, especially in children. Speech and language development can be affected in children even if the hearing loss is mild, and even if it's unilateral, there will always be some effect of it. There are some studies that show, specifically with conductive hearing loss, so children with a history of conductive hearing loss perform worse in binaural processing, using both ears to process sounds. And then there are improvements in emotional and social factors on quality of life after treatment of conductive hearing loss in adults as well. Adults, even if they have a temporary conductive hearing loss, for example, if they have an infection, they have a flu, they have eustachian tube dysfunction after a flight, or let's say after diving, it causes a lot of discomfort, and everyone experiences this. We see a lot of patients in clinic who come in even one day after their flight. They'll say, "Bana, secure meziba," and it's uncomfortable. So the treatment of conductive hearing loss causes an improvement in quality of life in adults and in children. Okay, so first we have surgical intervention of conductive hearing loss. Okay, and we can talk about prosthetics for surgical intervention for conductive hearing loss dependent on the cause. So we can use grommets in the case of glue ear or otitis media. We can use bone conduction implants such as the bone bridge. We can use middle ear implants such as the sound bridge. Or we can use passive middle ear implants. So the torps and the porps, stapes, prosthesis, these are all passive middle ear implants. The vibrant sound bridge is an active middle ear implant. It's like a cochlear implant, but the transducer is placed in the middle ear. And then you have obviously cochlear implantation, which is the last step. There are also other options for eustachian tube dysfunction, such as eustachian tube dilation, which is another surgical intervention for conductive hearing loss. Now we have something like the bone bridge, we have something like the sound bridge, we have the passive middle ear implants. I'm not sure which ones you use here, but you can get the fluoroplastic ones, you can get the titanium ones. These are some examples of those passive middle ear implants. The first one that we can talk about is the bone bridge, which is an active bone conduction implant. Okay, and the indications for this are conductive hearing loss. So you can have a conductive hearing loss up to about 40 dB, or a mixed hearing loss. So you can have bone conduction thresholds within this area and air conduction thresholds within this area. You can also use it in cases of single-sided deafness. One ear is hearing, the other one's not hearing. Maybe there's atresia, maybe there's another issue on the other side. You can use it to take the signals from one side into the other cochlea. So you don't have to always use something like a cochlear implant to restore hearing in single-sided deafness. You can use a bone conduction device to take that sound across to the other side. Okay? and the patient must be of 5 years of age or older. So we have patients who are born with atresia or microtia. Before 5 years of age, you cannot do the bone bridge implant, so you have to wait. In that time, you have to use a bone conduction device. So you can use a bone conduction headband or a bone conduction hearing aid to help manage their conductive hearing loss until they reach an age where you can do the bone bridge. And obviously you should not have any other central auditory pathology. As we discussed yesterday, if you increase the sound or if you increase the transmission of sound to the cochlea, it will not solve any neural issues that might be there. So if there are any neural issues, any processing issues, any neurological issues, the use of an implant will not solve those problems. Okay? Finally, the last one that we look at is the temporal bone. We have to make sure that there's enough space in the temporal bone to put the implant there. If there's no space, then you cannot use the bone bridge. Okay? Now, there are many studies that show the benefits of the bone bridge in conductive hearing loss and mixed hearing loss. So, the first one is that it's discrete. So, the headband is a huge thing that the child wears or the patient wears. With the bone bridge, it's just like a cochlear implant. It's a small processor that you just put on top of the skin. Okay. The other thing is there's no pressure on the skin. So unlike the headband, it's not pressing against the skin. It's sitting on top of the skin with a magnet. There's also direct stimulation of bone. So the transducer, which is this here, is implanted into the bone. It's embedded into the bone. So it's directly stimulating the bone and not the bone through the skin. With a bone conduction hearing aid, you're going through the skin and then you're going onto the bone. With this, it's directly stimulating the bone. There's no feedback because it's taking the sounds electronically into the transducer, and you can do auricular reconstruction at a later date despite doing the bone bridge. So the bone bridge will solve the problem of the patient's hearing, and then for the aesthetics, you can do the auricular construction. Auricular reconstruction is something that is a mixed topic, of course. We don't know how successful any grafts would be. We don't know how much the reconstruction will take. So you can plan that at a later stage, and in that time, the patient is using the bone bridge to hear. You can do the reconstruction later, and the patient will still use the bone bridge to hear. So it will not affect the function at all. It's a very short and easy surgery. Very short. Like it's just drilling a well for the mastoid and then placing the transducer in the mastoid, and you close. And then the most important one.
A specific place in the mastoid.
So the best is over the mastoid, like just over the mastoid air cells there. Yeah. But you can also put it slightly over the dura. You can put it in a different places depending on anatomy. But the best place is just in the mastoid region there. And then the last one is that the skin is intact. There are other bone conduction implants that are used widely, but this is the one that keeps the skin intact. It's not transcutaneous. So there are other implants where you have the abutment or a titanium pin sticking out of the skin, and obviously that increases the risk of infection. This one, the skin is completely intact, so you have no risk of infection of the surgical site. Okay? And then there are studies that show the reliability and effectiveness of this. So I'll pass the presentation to you. But there's a lot of studies that show that active bone conduction implants show good audiological outcomes, good speech and language outcomes, and good quality of life outcomes. Okay? And the other thing is that you can use them in complex cases of conductive hearing loss. So let's say if you have cholesteatoma resection, you have patients where you have to do blind sac closure, you have to do closure of the middle ear and the ear canal, obliteration of the mastoid. You can still use the bone bridge in mastoid obliteration and canal wall down procedures to restore the hearing. So yes, maybe you have to close the entire ear and nothing in the middle or outer ear is available, but the bone bridge can still be implanted so that the patient can hear. Okay? So even in complex cases, there are some reports that allow you to use it to allow you to restore function to the patient's hearing. Now, the vibrant sound bridge is a middle ear implant. So it's an active middle ear. Yes.
What if the inner ear is not implanted? Well,
So-
the same question, how do you confirm before you do the...
So you will confirm through doing a bone conduction test. So you'll do either bone conduction audiometry or bone conduction ABR to ensure that there is bone conduction function. If your ABR bone conduction or audiometry bone conduction does not show a response, then you would not use a bone conduction implant, you would use a cochlear implant. Yeah. Okay, so if the inner ear hair cells are not functioning and not picking up sound, then we're not using a bone conduction. This is only in cases where the outer and middle ear is compromised and the inner ear is working fine. Okay? Now, when we talk about the vibrant sound bridge, it's an active middle ear implant. So a transducer is placed in the middle ear. You can use this in some cases of sensory neural hearing loss. You can also use it in conductive hearing loss. And the indications are fulfilling criteria like this. So bone conduction thresholds can be here, air conduction thresholds can be here. You can have a conductive hearing loss or a mixed hearing loss. Again, you need to be 5 years of age or older, and the hearing loss needs to be stable. So you need to make sure that that hearing loss is not progressing. Because if that hearing loss is progressing more than this, then there is no benefit to doing the sound bridge over doing a cochlear implant. Okay? And again, we're looking at no active, because you're placing a transducer in the middle ear. The middle ear cannot be filled with fluid or pus or effusion. So you have to make sure that the middle ear is not effusing. Finally, you need to check the anatomy. So depending on what coupler you use for this, you have to make sure that the anatomy is okay to perform the active middle ear implant. Okay? Now the benefit of this is that you're bypassing the external and middle ear. So what you're doing is, you're not doing a cochlear implant where you're implanting into the cochlea, but you're placing a transducer inside the middle ear. So you have the receiver there, and the stimulator is either placed on the stapes or against the round window like that. So there are a few different couplers that you can use, and what literature says, what patients say, is that it's more natural compared to hearing aids. So yes, it's an implant, but the sound is more natural compared to hearing aids. Okay, there are some indications for doing this, and literature even finds that there is an improvement in audiology, an improvement in quality of life measures, and in some cases, it's a more safe and stable solution in patients compared to conventional hearing aids. Okay, so it is a proven solution for conductive hearing loss and mixed hearing loss, especially in cases where you don't have an external ear or there's some issue with the external ear that prevents you from putting a hearing aid. Okay. Now, those were active middle ear implants. We'll talk about passive middle ear implants, which is the titanium prosthesis for tympanoplasty, for stapes surgery, for ossicular chain reconstruction, and there are many different form factors. So you can use stapes pistons like this, where they attach to the incus and then they're implanted into the, or attached to the stapes. You can use the porps and the torps, where they're against the tympanic membrane and then attached, coupled to the head of the stapes. Other ones are like this. These are all different form factors. So these are the total prostheses, these are the partial prostheses. Okay? That's how they're placed. So there you have partial prosthesis, where you have the head against the tympanic membrane, and then this is just on the head of the stapes, and this will passively take those sounds. It replaces the function of the middle ear, and it takes those sounds into the cochlea. You have the stapes prosthesis, which will crimp onto the incus and then go into the oval window. Okay? Now, those were all surgical interventions. Now we'll talk about non-surgical intervention. So, conductive hearing loss compromises this system here. We have two ways of solving it. We have air conduction devices and we have bone conduction devices. Those are our two options for non-surgical intervention of conductive hearing loss. Okay? When we talk about air conduction devices, we talk about conventional hearing aids. So let's say a patient has chronic otitis media or even acute otitis media, chronic eustachian tube dysfunction, chronic conductive hearing loss, mixed hearing loss. We use conventional hearing aids in these patients where the ear canal is patent. So you have to make sure that the ear canal is patent for the use of an ear conduction device, because you're putting something inside the ear canal. If that ear canal is discharging continuously, there's no point of putting a hearing aid there, because you will always have that discharge blocking the hearing aid, spoiling the hearing aid, and you will introduce something that is creating a more moisture-filled environment in that ear canal. So we have to be careful when doing it. And if there's obstruction of the ear canal, so if there's oral atresia or microtia and you can see the canal is plugged, there's no point of using an air conduction device, because you know that sound will never go through. The hearing aids are going to be programmed to the ear conduction thresholds. We can use patients, so we can use in patients with recurrent discharge, we use BTEs and we use them with venting. Venting allows some air to be exchanged between the ear and the outside, and the BTEs are placed behind. So you know that even if it discharges into the ear mold, the BTE itself will be functioning fine compared to in-the-ear hearing aids or rigs. Okay. Now there's bone conduction hearing aids as well. So what bone conduction hearing aids do is the same thing that the bone vibrator does in audiometry. It bypasses the middle ear and the external ear, and it sends sounds via bone conduction directly into the cochlea. You place it on the mastoid behind the ear, and you have two conventional options. So you have the bone conduction headband, which is like that. It's just a headband that you wear. You can have it in this sort of hard band style. You can have it in a soft band style for kids like that. There are many different options for their attachment. Or you can have them in spectacles. So the bone conductor is there, and the spectacles, once you wear them, they're actively stimulating the mastoid. Okay? And then you have, okay, so yeah, so these will be used for bone conduction thresholds only within the normal range. They're not recommended for use beyond that normal range. Anything more than 35, 40 dB, you would not use a bone conduction hearing aid. Okay? It would not give you enough benefit, because now it's a mixed hearing loss, it's not a conductive hearing loss. Okay? And then you have an adhesive bone conduction hearing aid. So we have the Medel Ad here, which is the adhesive one. And what this does is you have a sticker that's placed behind the ear on the mastoid, and you attach the processor on the sticker like that. Okay? So the patient places a sticker there, and then they just attach it there, and it carries that sound in. The benefits of this is it's more comfortable than the headband. It's more discreet than the headband, because now they're not wearing a giant headband. Okay? And the sound is comparable. It's easy to handle and use. And again, for pediatrics, we do have a headband as well. So for pediatrics, you can make them wear with a headband. And later on, as they grow up, they can use the sticker. So it's a more comfortable, more discreet solution that provides the same or even better results. Okay? These are the indications. So like I said, you can only use it for a certain range, so up to 25 dB for the bone conduction thresholds. And there's evidence that shows that this solution provides similar benefit to bone conduction implants, so the Baha and the bone bridge. So you can use this as a good alternative while you're preparing for those surgeries where you need to. Yeah, so again, it's the same thing where you have improvement in hearing and improvement in quality of life. Okay? Now the takeaway from this is that all bone conduction solutions, most of them or all of them in studies, have shown good benefit in audiology, in speech and language, and in quality of life. If we have patients with conductive hearing losses, we should not neglect them. We should not, wait and watch. Even if they have a conductive hearing loss that's chronic for a few months, we should see how we can manage them best, either prosthetically or surgically, but we should be giving them an option so that they can improve their quality of life and improve their hearing, especially in children. Okay? So yeah, that's it for the prosthetics. Any questions about those? Bone conduction hearing aids prices vary depending on manufacturers and depending on the form factor that you go for as well. So there are different companies that make them. I'm not sure because we tailor these, we don't keep them in stock, so we tailor these solutions for the patient depending on what they need. So for example, if a patient needs spectacle ones, we need to find a manufacturer who does the spectacle hearing aids. If they use the adhere, we need to find the package that works for them. So at the moment, it's not something like these hearing aids where they're in a drawer and they all have a specific price. We tailor them to the patient accordingly. Yeah. So patient by patient, it does differ. We're looking into a couple of different manufacturers as well for bone conduction devices. So at some point, they might be a bit more widely available with a price list available as well. Yeah. But generally, they're around the same price of hearing aids. Yeah.
What about in Tanzania? Anyone has started using them?
We have quite a few patients with bone conduction devices. We have patients with single-sided deafness who are using bone conduction device. We have patients with atresia who are using them. And we have patients with chronic conductive hearing loss. So we have used them for all patients. Yeah. We've used the spectacle ones, we've used the headbands, we've used the adhere. No implants. So we haven't done any middle ear implants or bone bridge, but we're planning to do them soon. Yeah.
And the outcome is good.
Outcome is excellent. Yeah, outcome is excellent. I have a video, I'll show it to you actually. So this is a patient who is using the adhere device. Where's the volume?
Ayubu naona Ayubu yuko hapa Ayubu. Anazunguka anaenda kirudi. Kama harusi ile kwaina mwenyewe.
The shortcuts not.
Nibe. Ana trace ya nasema kule unaona. Ni syndromic yani.
Yeah, anayo atresia. Upande zote mbili. Yeah, the ear canal is completely plugged. I have the scan of it and there's a bone all over where the tympanic membrane should be. Is it working now?
Yeah. Steve, yuko wapi? Ameenda wapi? Ameenda today. Samuel yuko wapi? Ameenda wapi? Ameenda kwa teacher. Na wewe yuko wapi? Ndio ameenda shuleni. Yuko ameenda display kwa sema kwa. This is very yani mwili ya monotonous. Hiyo ni hearing aid. It's time when you are learning
So he had speech before?
Very, very diminished speech because he had a conductive hearing loss since birth of about 60-70 dB. So he could hear very loud sounds, but he couldn't hear, So we fitted him with the bone conduction device, the adhere. He's been using it for like 3 years now, and we're planning for his bone bridge surgery soon. Yeah. We talked with some surgeons about, he said it would be very difficult to reconstruct the middle ear and open it up and let him use it. So he's like, even if we do anything for the reconstruction, he will need to use a bone conduction device.
So it's better for bone bridge, right?
Yeah, so we're prepping him for bone bridge. Okay. Any other? Yeah. So, but bone bridge actually is very, very simple because we did some training courses. We don't need a surgeon to come and do it. It's very simple. If you come to DAR, just tell me one of the days. I will organize a session for you. It's really simple. I'll show you how. It's easy. You can do it 1 or 2, just temporal bones, and you can do it. Yeah. Okay. Any other questions? Amila? How to manage patients with them. Okay. Signia is a company that was formerly called Siemens. Siemens everyone knows. So the Siemens Hearing Instruments division became Signia in around 2016, I think. Yeah. So it was 2015, 2016 where it comes under Signia. And in 2019, Signia merged with Widex, which is another top manufacturer of hearing aid, to form a coalition called WS Audiology. Okay. Here in Tanzania called the Prompt devices, which are the digital behind the ear devices. They have 8 channels, and you can put 4 programs on the devices, and we have them in the country in the dark brown color. Okay. We have 2 variations. We have the P and the SP variation, and the difference between this is the fitting range, and you can fit them with ear molds or ear tips. Okay. These are the fitting ranges for the devices. So Prompt P goes from mild hearing losses up to severe hearing losses, and then the SP goes from mild all the way to profound, and it uses a bigger battery as well. Now, when you start the fitting process, not for children mainly, but for adults, it's important to try the hearing aid. It's important to try the hearing aid for them according to their hearing loss, so they can see what the hearing aid feels like. Sometimes we feel a bit lazy and we don't do a trial, and we do all the counseling and we tell the patient to come back when they want to get the hearing aid. But the biggest difference that you can make is by making them wear the device. Even when you go to, the optician, they don't just tell you you need glasses, they make you wear those lenses so you can see how clear it's making your eyes. So you know what difference it makes. So you have to inform the patient first of what difference it makes, but the biggest thing you can do to show them what difference it makes is by trying it for them. Okay? It might take 10 or 15 minutes more, but it's an important part of the process for a hearing aid patient. In children, generally you won't see the difference immediately in a majority of children, so you can make them wear the device, especially in profound hearing loss. So we would go ahead with fitting regardless of what the trial shows. Okay? And the explanation is important, that when you try the hearing aid, some patients might be like, kuna kelele nyingi, nasikia sauti yangu zaidi, or my voice is a bit louder, it's more heavy. You have to explain to them that 1, they will get used to it. 2nd, it's not the final fitting. There will be many adjustments that you will make along the way. Okay? The patient has to know that it's not something that they buy and then they use for like the next 10 years the way it is. We can adjust until they're comfortable. When you encourage hearing aid use, the biggest problem that we have with hearing aid fittings and hearing aid professionals is that, and patients as well, is that we talk about the price. The price is high, the price is high, the price is high. But we should be talking about the value that that price is giving you. Okay? So yes, are they expensive? Yes. Can they be for some people a bit unaffordable or out of their budget? Yes. But you have to look at the benefits and you have to look at the value of these things. It's not something that we are doing just for aesthetics. Nobody is wearing hearing aids just because they like them. they're wearing them because they're proven benefits, scientific data that shows the benefits that you get from hearing aids. So when you counsel a patient, when you talk to a patient, we can't always talk price. We have to tell them that yes, this might be the price, but this is the value, this is the benefit of wearing a hearing aid. Even in mild cases, you have patients sometimes with normal to mild hearing loss. Elderly patients with the start of presbycusis, sometimes they'll say, okay, but I have a small problem, this is very expensive to treat a problem that's mild. But there are studies that show that even mild hearing losses can contribute to cognitive decline, to social isolation, to dementia, to Alzheimer's, to all of these things. So in view of that, it's better for them to use the devices to mitigate those issues than to let the issue become too big before you go for management. Okay? It's a medical expense. So if a patient needs a surgery or medication, they will not treat it the same way. You cannot, if you're a doctor, you will not talk about the price, or you will not be scared of the price of a procedure. Like kita di tympanoplasty, kita di prosthesis, or whatever they need. You will, if that's what it costs for that medical expense, it's the cost of that medical expense. So we have to think about it in those terms, and we have to think about, counseling them effectively. You have to counsel them in a way that makes a patient feel like this is something that will help them, and it's not something that they're just wasting money on. And the last thing is to show them that when you make them wear the hearing aids, when they start using the hearing aids, they see the benefit that they're getting from those hearing aids. If they have issues, they come back, you adjust them, so they have to be part of the process, and you have to manage them as patients who, you're giving a greater quality of life, and you're giving someone access to sounds and access to things that they would not have without the hearing aids. Okay? So that's the main thing, that with hearing aids, sometimes if you give in to the patient's complaints about the price and you say, okay, whatever, you will not encourage them to use the hearing aid, because you're viewing it as something that's too expensive compared to something that will make their life better. Okay? Now when you're selecting the right hearing aid or selecting the coupling, you will check the fitting, you'll check the fitting range, and then you will either take an impression or use an ear tip. You have to make sure there's no feedback, and you have to do the fitting after the ear mold is done. So you cannot do the fitting and then get the ear mold later. You have to do it with the coupling that you will use. Okay? This is what you generally have before you do the fitting. So you have the computer, the cables, the adapters, hearing aids, ear molds, batteries, and then the patient's details and test results. Okay? This is the Connex 9 software, so we will not go through the software because that's not the aim of our presentation today, because it's something we've touched on before. So the software is exactly the same. Okay. Yeah, proceed. Okay. And then after you do the fitting, you need to verify your fitting. So you need to do subjective tests, clap, talk to them, stand behind them. Similar to the video that we just watched, that's exactly what we do to make sure whether it's an adult or a child, you'll talk to them in different ways. You have to be careful when the relative is talking to them, because a lot of times you'll make them wear the hearing aids, and then the relative will turn around like this and go, right? And you have to remind them that these are not superpowers, these are not devices. I can't hear you.
They're not magic.
They're not magic. Whether they're wearing hearing aids or not, you can't turn away, talk very fast and very low as well. It doesn't work. You have to talk to them clearly, have to talk to them at a normal volume, but you cannot talk to them, you cannot whisper to them from this distance and expect that they will hear it just because they're wearing hearing aids. Okay? So you have to counsel the relatives also that they're not magic devices. They will not improve your hearing to an extent where you're hearing everything and understanding everything as well. So the second thing is understanding. The patient might be hearing now, but that doesn't mean that their brain is used to catching those signals and interpreting them. So patients have to be counseled also that now you're hearing sounds, but you won't be able to interpret them within 5 or 6 seconds. It will take some time to get used to it. It takes some adjustments. It takes some practice and training. And then you will get to a point where now you're understanding things easier, now you're getting things clearer. You also see the opposite type of patients. Once you wear the hearing aid, everything is perfect. They can hear, they can speak, they can understand, they're happy with them, and you'll see both patients. But you need to verify for both of them. You can also do something like sound field audiometry, speech testing, things like this to make sure that the fitting is accurate and the fitting is helping them. Okay? So we have a step for counseling. So once you've checked that the hearing aids are fine, you've put the patient, now you need to counsel them on use of the device. Spend about 10 minutes showing them how to wear it. The most important thing is how to wear it. I have many new patients that come in 1 week later and they say, bana hearing aids napiga kelele sana, hazisaidii, siwezi kusikia. Okay, wear the hearing aid. You see them putting it like this, it's half outside the ear. It's not going to work. You have to re-counsel them on how to wear it properly, and then once they wear it, once they wear it properly, they should be able to hear properly. Okay? We have created a leaflet. So what we did was we made this little instruction leaflet and we put all the points in Swahili over here and our contact number here as the service center. So we created booklets of this. We don't need to print them. We just made booklets, and then we need to tear the booklet, tear the leaflet, give them. So we give all the patients this, and we give them the English booklets as well, because that has pictures and all of that. So I'll leave this with you. You can make your own, and you can give it out to patients. It really helps because they have all the information on one leaflet. Okay? We also have the app that we discovered last time, so you can give them the option of using the app to control the volume. Okay? And counseling them on the use and maintenance is important. So moisture and sweat is the biggest thing that can destroy the hearing aids. Water should not enter. They should be counseled to wipe the hearing aids, to clean them properly, to bring them in for tubing, to bring them in for service. If they have a drying capsule or a dryer, they should use those. Turning off the hearing aid, turning it on, using the volume control buttons, all of these things you need to inform them. And the important thing is service. So every 3 to 6 months they should be bringing in for service. You should clean them, you should put them in the dryer, you should change the tubing on the ear mold to make sure they're functioning okay. We have a few accessories that we use to improve maintenance. These are optional accessories for patients. We have those silica drying capsules that you can give to patients. We have those electronic dryers that you plug into the power and then you use every night. We have protector cloths that go over the hearing aids and take the sweat out. All of these are different accessories that can be used. And of course, we have spare parts like ear hooks and battery doors and all of these things for repairs, for management of these patients, so that, oftentimes what happens is that a patient gets maybe different hearing aids or hearing aids from outside, and then they come here to Tanzania and we don't have anything. The ear hook might be broken, but he has to buy a new hearing aid because we don't have the ear hooks here. Or the battery door might be gone and we can't do anything because he got them from the UK or the US or wherever. So that's the importance, and we make sure that we keep these in stock. So if there's any repairs, then you can always get in touch with us and you can send them to us. Now, we discussed this last time, but we also made a service form. So I don't know how you use them for your lab, but we created a form for troubleshooting and service where we put in the issues and what is done for the service. So I'll leave this with you as well. Okay? Yeah, just give me 2 minutes. We'll finish them, okay? And then the other thing is feedback. Of course, we know we don't want whistling, so we have to check the ear, make sure that the loud sounds are not too loud. We have to check the fitting is okay, it's not sitting outside. Feedback is one of the things that can reduce hearing aid usage. Own voice perception is another thing, but again, we've discussed that in the software and how to reduce it. So they have to be comfortable with their own voice, but not that they can't hear their own voice, because then they can't hear our voices, okay? And for pediatric fittings, we know we base them on the ABR or the ASSR and not the audiometry if we don't have an audiometry. So if the ABR is showing 90 dB, then we will use it at 90 dB. Okay? Auditory neuropathy, like we discussed that case yesterday, the ones where if you make them wear hearing aids, still they're not interpreting sounds properly. We haven't got an exact protocol for management of those patients yet. So even if you make them wear hearing aids, sometimes it doesn't help because those increase the sound, but the nerve is not taking those signals or interpreting them correctly. Okay? And if there's any additional support, of course, we can provide. We have bone conduction devices, in-the-ear devices, rigs. We've done this, I think, in the past as well. So if there are any additional requirements of your patients, or even if there are patients who are a bit difficult to fit, let's say you have adjusted 3 or 4 times, like he's not happy with the hearing aid, he's not hearing properly, you can always forward them to us or call us and we'll provide that support in how to fit them properly. The last thing I will show you is a new form that we have made for ear molds. Okay, so this is an ear mold request form that we use for other centers. When they take the impression, they attach them to this form. They will fill in the details, the hearing aids, the findings, and which ear mold they want to request. So you can request maybe a hard mold, a soft mold or something, and attach it to this and then send it to us. If you need an ear mold that's a bit special, if you need an ear mold that's maybe a bit difficult to make, we can make them if you send us the impressions. And you don't have to attach them to this form. I'm just showing it to you as something that's an example of what you can use to make your systems and your processes more efficient as well. Okay? So from the hearing aid side, that's all that we're going to discuss today. Are there any questions about the hearing aids? Okay. Okay, excellent. Yeah. Yes. I will give you the electronic version as well. The presentation takutumia. I'll send you all of them. Okay.
Let's go. Now, what will